Okay, don't jump. Thank you, Chief. I'll try not to. Um, you don't like this background, huh? We can find a different one. How about this one? Steve, you on?
Yes, sir.
There you are. Hello, hello. All right.
I lost my button.
What's that?
I lost my button, so I'm looking kind of debonair.
Okay, man, whatever. Whatever. There we go. Hello, hello. Yes, you can hear us. I love it. Fantastic. Steve, where's Ed?
He's coming, I guess.
What channel do I call him on? Somebody tell me. Is it
Foxtrot.
Foxtrot?
Yeah.
Let's try.
Low priority B. Bravo. Low priority B. Low priority.
Oh, geez. I got to go into the menus.
Sunstar B. Sunstar D. Sunstar E. Sunstar F.
Bring back Glenn's picture. I don't know if I can do that to Gary again. Hang on a second. Let me see if I can get Ed up here. All right, dispatch is trying to get us our last person. So we'll go ahead and get started while we're working on that. Thanks everybody for joining us. Our topic for this afternoon, our guests are Steve Fravel and hopefully Ed Wilson to answer any EPCR questions. Before we get to that, we will go through a general update. As I'm sure you're all pretty well aware, case counts are on the rise. Excuse me. And so I'll just go ahead and start showing a couple of numbers here. So if you can see this screen, I think what's clear is that our number of positive tests or cases, that's easiest to see here on this blue line, new positive cases per day are on a significant, like exponential increase. And the 14-day rolling average of new cases is also increasing. So essentially what we're looking at there is a return to exponential growth, sort of what we saw before we did flattening of the curve. So I think this is probably a result of some of the relaxing, and somebody said it in a funny way earlier today that I heard. They said that we are officially now in phase 4 of reopening and pretending like COVID doesn't exist anymore. So I think it's important to just reemphasize where we are here. Excuse me. So a couple of things I want to share just in terms of the current situation. Case counts are rising rapidly over the last 2 weeks. Both the total number of cases and the percent positivity are on the rise. The average age of our cases are dropping, with young adults making up the largest number of new cases. So we continue to have cases in our long-term care facilities and nursing homes, but very clearly we're seeing a shift to the younger population. You probably heard about some of those bars down in St. Pete that had some staff members test positive and have now closed. So I think it's clear that we're seeing a shift there. I think it's also clear that infection control practices among the general public are intermittent at best. I do not see enough people wearing masks. I see lots of people in big groups, whether that's inside restaurants or bars or shopping malls or wherever else. I see people traveling again. I do not see everybody wearing a mask like they were before, and I don't see people necessarily doing hand hygiene or environmental cleaning like they were previously. So given all of that, it's a little concerning, and add to that we're having significant increase in cases among healthcare workers, among law enforcement officers, detention officers, the 911 center itself, as well as we've now had several cases of responder to responder transmission here in our system. Put all of that together with this virus itself, the SARS-CoV-2 virus, which is the causative virus, it is able to be passed on surfaces or objects that are contaminated. It is able to be passed via droplet, and it is able to be passed via airborne, depending upon the circumstances, and it is highly contagious. Our very nature of our work, including living in stations or for long hours on vehicles together, makes social distancing difficult to do. And as restrictions are lifted and cases rise in the community, we all should expect to have increased exposures both in the community and on duty. And I'm talking about from patients and from coworkers. So I think that everybody just needs to remember this. And I would say, as of today, and I know none of us want to hear this because we're sick of it, and I'm right there with you. I think that we all need to know that our risk of exposure and illness among our group of first responders is the highest that it has ever been throughout this entire pandemic today. And I expect it to continue to rise for some time. So that risk is from patients, that risk is from congregate work settings where social distancing isn't happening, and that risk is from off-duty and community sources. All of these exposures are real and are occurring. So what we really need is to enhance our prevention measures for the safety of ourselves, for the safety of our patients, and for the safety of our families when we're off duty. I think we also have a responsibility, for lack of a better way of putting it, to model good behavior in the community. The way we conduct ourselves, both on and off duty, is something that people pay attention to. And I think we have an obligation to set the standard for how people ought to behave. Choosing not to wear a mask when you're in public in a large group or in the grocery store or somewhere where other folks have to go could be spoken of in terms of social responsibility at this point. And so I think that that's an important thing to remember. So I'll pause there. There's a couple of questions that I will try to chat or try to discuss. So I have one question that says, rumor has it there's a few departments with lots of personnel that have tested positive. Is this on the job exposure, or do you see this happening more? That is true. Unfortunately, we have had several system responders test positive over the last week or two, including at least one department where nearly basically an entire station, all 3 shifts. That's a real thing. The answer is that is not necessarily from a patient. That may be from somebody who inadvertently, started feeling sick while they were on duty, or inadvertently had an asymptomatic exposure and infection. So this is something that I would like to refocus everybody on. You can say what's a handful or lots, but it's more than I'd like. That's for sure. When you have an entire station that essentially has to shut down and get cross coverage, that's a significant impact. And I think we could all probably learn from that. The transmission in a setting where we're all sharing space, whether that space is in a kitchen or a bunk room or a ready room or the cab of an ambulance or the cab of a fire truck, these are potential routes for exposure. I think it's interesting to note. I don't want to go too much into the specifics. I see some of the comments, but as of 2 weeks ago, we had only had 2 first responders or responders, however you want to say it, fire and EMS folks in our system. As of a few weeks ago, we'd only had 2 test positive, and that number is much higher today. Just off the top of my head, I've got at least 4 to 6 more in the last week or 2. So, and there's a lot of tests still pending. So I think this is something real and we need to take it seriously. The interesting thing is the virus behaves exactly how you would expect it to behave. So here's a question for you. If you decided for some reason that you wanted to get on an airplane right now, I don't know whether or not I would advise that, depending on how important the travel was maybe, but I know at the hospital, if I get on an airplane, I'm off work for 2 weeks without pay. So, there's that. But if you got on an airplane right now, I'm pretty sure you would want to wipe down your seat area. And I'm pretty sure you would want to wipe down your tray table and the armrests and all of that before you sat down in a chair that somebody else just got up from. And what's interesting is, does the same thing apply to, the cab of your engine or your bunk room or wherever else? I think it's interesting that we need to think through some of the ways we can best do risk mitigation. So I just want to refocus everybody on that. Again, I don't want to get into too specific numbers because it's still in flux, but I've got, just thinking on the top of my head, somewhere probably between 5 and 7 new cases among system responders in the last week and a half or so. And that actually mirrors what's going on in the community. We are part of the community. So, it's important that people are cognizant of that fact. So Rick, I'm not sure I truly understand your question. Are you asking how many of the positive tests are actually symptomatic? Or are you asking something different? I'm not exactly sure. Chief Bessler, yes, I would love to have my beard back. If anybody knows where I can find a pepper that I can buy, I will grow a beard back immediately. Rick, okay, so the uptick of new cases. No, these are not asymptomatic cases, Rick, at least not the ones I'm seeing in the ER. We're seeing, every ER I've talked to actually is seeing a significant uptick in younger folks coming in with flu-like illness and testing positive. And so, yeah, that's They are sick. Now, thankfully, the hospitalization rates and mortality rates are not going up um, as, as fast or yet. But the thing to remember is that people generally have a relatively mild course of illness for about a week. And then if it's going to get worse, then it gets worse after that. So I'm honestly a little nervous about what we're going to see next week in terms of hospitalization rates, respiratory failure rates, et cetera. I think there's more than passing chance that we're going to see some spikes in our hospital utilization and number of sick people in the next week. Now, fingers crossed that these are young, healthy people and most of them don't get that sick, but I am a bit concerned. I'm also concerned because these numbers and this uptick of cases seems to be as a result of the initial phase 1 reopening, and it will still be several weeks before we see the impact of phase 2. So the overall message is that people seem to have decided, for whatever reason, that this is over. They're either done dealing with it, they're sick of dealing with it, or because some of the restrictions got lifted, people just decided that it's over. And like I said earlier, somebody sort of tongue in cheek earlier today said, well, I guess we're now officially in phase 4, pretending that COVID doesn't exist, because it's definitely not over. And in fact, just to put it in perspective, the last 2 weeks, just the last 2 weeks, we've been dealing with this for 4 months, and 1/3 of all of our cases have been in the last 2 weeks. So we are seeing significant rise. Frankly, the curve is not flattened anymore. We are back at that exponential rise, and that is troublesome. So I guess I would just implore you guys to be safe, protect yourselves. I know we all want it to be over, but it's not, and it's not over by a long shot. And anybody thinking about having a chickenpox party and, well, we'll just get to herd immunity, there's a lot of pain and suffering and death between here and 70% of our population having developed this. So please, wave 1 of this thing got slowed down by all the amazing work people did over the last few months and all the sacrifice that people made. But it's not over. I don't even think this is wave 2. I think this is just the continuation of wave 1 now that we've relaxed some of the restrictions. So I know this is not the prettiest picture, and I know it's a little concerning, but I need people to understand the reality that right now the virus is in the driver's seat and we are along for the ride because we are currently not, as a community, and I'm not talking about us at Fire and EMS, I'm talking about us as a community, we are not doing the things that we need to do as a community to slow this thing down, let alone to stop it. And until we do that, we're at the mercy of this thing. This virus exploits our very nature as social beings. We all crave and need as part of being healthy social interactions, and that's our weakness as humans that this virus exploits. So just understand that when you want to go out to dinner, when you want to go out to the bar, when you want to do whatever it is you want to do, go on your trip or hang out with the folks you haven't seen in a while, understand that there are consequences of those actions, not only to yourself, but to your coworkers, to your family, to our patients, and to the community as a whole. And we need to think very seriously about how we conduct ourselves on and off duty. Just to be clear, we have multiple new cases among our ranks in the last week and a half. And I don't see any evidence that this is going to slow down unless we really reassess as a community how we're doing. I see a couple of questions about recommendations. So Ross says, what's your recommended procedure on PPE for personnel when patients go into cardiac arrest during treatment, and OD that arrests within 1 to 2 minutes of at patient? Well, Ross, I hope you're in baseline PPE with N95 or P100 and eye protection. on every patient encounter. And if you come across somebody who's an OD who's needing ventilatory assistance, then by definition, you're doing aerosol generating procedures and you should be donning your full PPE ensemble on that patient, even while you're squirting some Narcan up the nose. That type of intervention or even BVMing them while you're working on that should be in full PPE. Now, if you have a patient who's not doing that aerosol generating kind of stuff, at least when you get there, that's the whole purpose of the baseline PPE. But ideally, if something changes and you move to that realm, the smallest number of people should continue care in their baseline while others, get into the appropriate PPE to take over, and then let those folks back away and do the same. There's, excuse me, nothing is ever by the book. But the whole purpose of the baseline PPE is for the scenario where we don't expect an exposure, but then one comes. So hopefully that answers your question, Ross. Recommendation on big firehouses, for instance, some of the larger stations. I'm not going to make individual recommendations to agencies or units or anything like that. I would just ask folks to take a minute, both, and by folks I mean both the boots on the ground responders and the leaders of our system, to take a minute and think about what else we can do to protect ourselves, given that our risk is now the highest it's ever been, and given now that we have seen the ability for this virus to spread between us while we're at work. So again, I'm not going to make specific recommendations. There are recommendations coming out. I saw a piece from IAFF today that I heard about, that they are now recommending wearing masks at all times in the station. And so, there's some thought and consideration that folks need to do on that. But I'm just asking you all in the meantime to think for yourself what you can do, both on and off duty for your family, your patients, your coworkers. Do you really need to go out to dinner? Do you really need to do these things? Or can we find an alternate way to continue living our lives but minimize the risk? So I'll just say, are there any other questions to this particular stuff? Throw them up there and I'll do my best to answer them. Otherwise, the next question I have for you all is, who else would you like for me to bring on these YouTubes? So far we've had Dr. Antevi, we've had Dr. Shepke, we've had, we're going to have Dr. Pepe come on. And I can certainly ask some others if they'd be willing to, but if you have somebody that you'd like to hear from or a specific issue you'd like to hear on, I think Dr. Pepe is hopefully going to talk with us about the hypercoagulable and hypocoagulable states that we're seeing in some of these folks, so from the clinical aspects. But if there's anybody else that you guys would like for me to try to get to come on with us, please let me know. Stephen asked any status update on system-wide testing. Sure. So we did our initial testing of 30 people as part of our validation. That included one previously known case who, as expected, tested positive for the antibodies. We did get 2 individuals who tested positive for the IgG, which is the longer term, not I'm sick right now, but I've been sick previously, antibody. However, when we sent both of those to the lab, they were negative in the lab, meaning that this was likely a cross-reactivity with a previous different coronavirus infection. Specifically, over this winter, we had pretty good amounts of common cold coronavirus circulating in the community. So most likely reason for that is those 2 individuals had previous infection with a non-COVID-19 coronavirus. So we're still working through the data and crunching the numbers, and I hope to have a plan within the next couple of days on how we're going to move forward. I still believe that there's some value in this particular test that we got as a screening tool, and we may just have to say that anybody who tests positive with the IgM goes for a nose swab, and anybody who tests positive with the IgG goes for a blood draw. And then anybody who's negative is good. The negative performance worked very well. So hopefully I'll have a plan and something together to share with you within the next couple of days. Okay, any other questions before we move on to our guests today who wanted to answer any questions that exist about ePCR stuff? All right, so with that, we've got Steve on the line. You there, Steve?
Yes, sir, I'm here.
Okay, and Ed, are you on the line as well?
I am.
Fantastic. Okay, so our two resident ePCR gurus are here with us. Do you guys have anything in particular you want to share before we start taking any questions?
Well, I'll share the experience we've had with the new closed call rules. I know that it kind of rolled out pretty quick for everybody, and I really appreciate all the effort you guys have done, especially with the additional time now it takes to close a call. And any closed call rules that are popping up, any of the red ones, I've only had half a dozen or so red ones pop up, but once I get them, I can clear them. So you have to let me know if you get them, then can't close your call. Those are the NMSIS 3 rules that have gone into effect now. And with that, I say thank you for your help on that, because like I say, I've only had half a dozen or so out of the calls that we've done, which is probably, well, over 1,000 now. So that's good news for me.
Wow.
Any comments on those? Any questions on those? And the question, Ed, you want to talk about the applied not applied situations, but the standoff assessment?
Certainly. So coming up as a phone number is myself, Ed Wilson. I'm telephoned in. My understanding is that the standoff assessment has been very little problem. The only time that it's come in weird is when there's been something like an organ transplant or something like that. And it's been very easy to work around. If anybody's had issues that you haven't brought to me, I hear from half of the system or half of the system providers-ish through our Sunstar Channel Foxtrot. So I've got a reasonable pulse on it all, and it's all been pretty darn easy and clean and smooth.
Yeah, I don't see any questions in the chat. Any concerns or questions about the new COVID-19 impressions? I mean, those seem to be going fairly well too.
I can't believe it. Nobody wants to complain about ePCR? Really?
Well, you got the. This is
when you think through it cleanly and really lay it out nice and neat. Hey, that will stir up some questions or comments, I bet.
Amazing, Chris. Perfect. That is, yeah, don't worry, Chief. Chiefs don't have to do ePCRs anymore, right? Or should I say, back when you were on the truck, it was still paper, and we used a little X-ray film in between the carbon copies. Chris is asking if we anticipate staying with the Zoll software for the long term. And the consensus seems to be that it's increasingly and unnecessarily unwieldy compared to other options. It's interesting that you say that. There was a survey a year or two ago that said that the user friendliness or user unfriendliness of all of the ePCRs was roughly equal. Now we have looked at some other ones in sort of general terms, but at the current time, there is no plans to move. But you know, you never know. I don't know, Steve, you got anything else on that?
Well, no, but the one driving force is the billing aspect of it, because what we're documenting, especially on the Sunstar side, is the billing information for Medicare, Medicare, and Medicaid and insurance to get paid on these. So we got to get paid so we can get paid. So that's a big driving force. And none of the other agencies or none of the other options for EPCR gave us the same kind of results that we have now. So we got to keep that in mind too. And I know Ed and I are very conscious and aware of any effects that when we make a change, how it affects the field crew. That's one of the first things we talk about is how it's going to affect the field crew. Is it going to be 1 click or is it going to be 2 clicks? Because 2 clicks is twice as bad as 1. Ed, your thoughts?
Absolutely. Perhaps unbeknownst to a lot of the system, we really sweat the details over trying to keep it as smooth as possible. One of the byproducts of this new switch over to reporting differently to MSTARS that's caused the new close call rules for fire, and Sunstar is going to be seeing some of that soon as well. It's going to allow us to remove a couple of fields. The very obnoxious subjective other primary symptom category, anatomic location, and organ system, we'll be able to make those go away. And that was required previously and is no longer, and we were quick to pick up on that. Back to you, Steve.
I'm looking at the question in the chat about the
Social Security number.
Social Security number to auto-populate information. Well, Ed, you might want to touch base on version 6.6 that'll come out, and they'll have some auto-population options with driver's license, etc.
Absolutely. We lobbied Zoll pretty darn hard to include a driver's license barcode scanning feature, and that's coming out in the next version. And so you should be able to be on scene, grab the patient's driver's license, and it plugs in their name, date of birth, address.
So that should help tremendously, I would think.
And when is that going to be?
This summer.
These IT questions of when a particular thing hits the street are always tough. We are working on it, and we hope to have it within months, not years. Steve, can you get more specific?
No, not
You're
really,
kidding,
because
right?
there's so many things involved with it, especially training is one, because there's going to be a lot of upgrades, a lot of different things like that with training. The training will be one. And then also infrastructure, because if there's more server hardware that needs to be purchased in order to make bigger hard drives, that's got to be considered also. So it's not just an easy, it's not like your phone getting updated, every other month. So a lot of moving parts in there.
I feel like there's a joke here about what's the difference between a weatherman and an IT person.
Hit us with the punchline.
I don't know yet. We'll see.
If you've got a good punchline, let's see it in the chat, please.
All right. So anything else from the group for our EPCR folks? And then also anything else about who you want to hear from or what topics you want to hear about, and they do not have to be COVID related. I think we plan to continue doing these periodically. So even if it's something completely unrelated to COVID, the cone of uncertainty. Alan gotcha. He said both weatherman and IT people are all about the cone of uncertainty.
I like it.
That's good. So what other topics in addition to COVID would everybody like to hear about? There's 45 of you on there, so chime in. Oh, okay. Yeah. Trauma doc at Bayfront. He was on my list to ask to bring in one of the trauma docs from Bayfront since we're doing PHTLS coming up this fall. So I will definitely keep pursuing that. Who else? What did I hear? Handoff, how to do a good handoff to ER staff. That's great. Chris, is there a particular ER doc that you know of that you want me to try and get, or just any ER doc? Or um, and let's see. That's it. We got 2 suggestions. Okay, well, we'll keep trying to find interesting and Dr. Bellini you want. All right, I will ask Dr. Bellini. We'll see. We'll see. See if Roberto will consider coming on. I'm gonna try and ask Dr. Osterholm. I don't know if I'll be able to get him because his schedule is super busy these days. But I'm lucky enough to be on a call with him every now and again, and he would certainly be a great person to have on. If you haven't looked at his website or listened to his podcast, I highly recommend it. It's CIDRAP, CIDRAP is the website. So if you haven't, by all means, do that. Michelle, somebody about legal documentation, EPCR. This is all of our favorites topics, isn't it? EPCR, but okay, we'll add that to the list. What else? So Mike is asking about blunt fills, and he says, are we able to look into the blunt fill needles? We brought it up last week. Yes, and I thought we answered that pretty well last week. Was there still a particular question, Mike? Or Tom wants to know what's the go-to whiskey for a pandemic? I don't know if you can see this. Let's see. There you go. That's what I would suggest, Tom. I don't know if you can see that or not. Okay, so in moderation, Chief, right? Healthy coping mechanisms. Let's see. Mike, was there a specific other question on the blunt fill needles that David didn't answer last week, or was it answered, I guess is my question. Because you're okay. So if I understand the question right, you're asking why do we have blunt plus filtered as opposed to just the blunt unfiltered? And if that's the question, we actually, when you have a blunt tip needle like that, you can actually get little pieces of the plastic or the rubber from the cap go in there. Also, if you're using an amp that you break off, theoretically, there can be a little piece of glass that goes in there and other particulate matter. If your medicine has some crystals that have come out or whatever. So the correct way to do it is to use a filtered needle. And believe me, I know it's a pain in the ass, particularly when you're dealing with drawing up bicarb or drawing up amio or anything like that. But the filtered needle is the correct way to do it. Any other PPE options on the horizon? User-friendly, cooler. Yeah, gosh, I wish. I mean, I don't know, maybe the hazmat guys can tell us if the PAPRs make that much of a difference, but we really can't get a lot of them right now. I believe Sunstar is going to start to see some of the Moldex full face respirators, which are maybe a little bit more comfortable. But you're right, Rick. PPE is going to be here for a long time, and man, it stinks having the little decubitus ulcer on the tip of your nose from your N95 that you've been wearing for 12 hours. I hear you. I know. I'm gonna do it again tomorrow. But we don't have a lot of better options right now. I hear that there are some new types of N95s in development that are supposed to be more comfortable, but I wouldn't hold my breath. That was a joke, right? I wouldn't hold my breath for them to get here anytime soon. That was for you, Chief Bessler, by the way. I hear that there's stuff in the pipeline, but don't know yet. No, we don't have a good alternate strategy right now. I wish we did. I know it's getting hotter and I know it's getting more uncomfortable. Maybe 10 years from now, you'll have a positive pressure thing that you hook into in the back of the ambulance and it blows nice cool air across your face, but not anytime soon, unfortunately. Okay, what else do you guys have? Anything else? Last call, Steve has got to leave, and Ed, I'm sure, is very busy today too, since it was a last minute kind of join.
I didn't see any celebration in the thread about getting rid of those fields in the subjective other. Totally expected that.
Well, Ed, I mean, I guess welcome to my world. You learn not to be disappointed.
Cool.
There you go. Yay. All right, I have to, this person is blowing up my phone. So put the last of your questions in the comments real quick, and then we'll wrap it up right after that. Okay, sorry about that. Hoses that the police use to cool them off in their cars, put a few in the back of the Sunstar for direct AC. Yeah, that's an interesting one. It would be cool. It's probably trying to figure out what the heck George meant, but no, it was not pizza. It was somebody with the title chief in front of their name, chief. All right. Unless there are any more questions, please stay safe. Please understand where we are in this thing. Please redouble your efforts to do good infection control at home, at work, with patients, and please remember to do whatever we can to model good behavior to the community, because the last thing that I want us to have to do is to go backwards and start locking things down again. But I can tell you it's already being talked about if we can't get people to step up their game on this stuff. So please be safe. And we will plan to be back next Tuesday, and hopefully with somebody interesting to talk to you guys. So in the meantime, again, stay safe. Let me know if there's anything y'all need. All right.